Good afternoon, everyone. We'll get started with a little video on Proton Therapy Academy, and then I'll get things going.
Proton therapy is more than technology. It's a revolution in cancer treatment. It's precision. It's innovation. It's hope. We believe hope grows through knowledge. That's why we provide expert-led training accessible across the whole community, because unlocking knowledge today is key to better treatment tomorrow. Together, let's transform patient outcomes. Proton Therapy Academy, from knowledge to treatment.
That was our introduction to Proton Therapy Academy, but I will tell you all about it now. So welcome all to this webinar on optimizing proton therapy through hypofractionation, evidence and early experience. And we're happy to share this webinar together with the team from the European Institute of Oncology in Milan. Here's our disclaimer. Let me see, because I think the screen is not showing properly. Here we go. So today's speakers, we have three speakers, Baba Jehecek, who's the chair of radiation oncology at IO and the president of ESTRO since now last week. Congratulations to her. We have Luca Bergamaschi, radiation oncologist, again at IO, and Daniela Alterio, who's deputy director and radiation oncologist at IO. You will hear from them in a few minutes. But I want to get started by giving you kind of a brief overview of Proton Therapy Academy. What is our mission and our network? And so why did we create Proton Therapy Academy? In a few words, we saw a growing number of centers. We saw a more diverse case mix. We saw increasing evidence on proton therapy. People value choice and where they train. And finally, there is innovation and therefore the need to train on this innovation. And so this is why we joined forces together with many centers, experts in proton therapy, to create the Proton Therapy Academy, from knowledge to treatment. And to come back on the different points, the growing number of centers, you see that in 2010, there were only 29 centers from all vendors in development, and now we're at over 179. That was data from late 2025. We see also a more diverse case mix. There was, of course, an increase in the use of proton therapy in the last 10 years. You can see here the data from the NAPT in the US, but also change in how proton therapy is being used, from a niche modality for a few indications to now widely used for things such as breast, lung, or head and neck, for example, to see some of the ones that have been growing over the past years. There is also increasing evidence favoring proton therapy. We saw it with the recent publication by Stephen Frank and his colleagues from different institutions across the US, which demonstrated that IMPT is a new standard of care option for patients with oropharyngeal carcinoma by showing an improvement in overall survival of 10% at 5 years. So this is really groundbreaking evidence that we saw from Stephen Frank and his team. People value choice as well for their training. They want to train maybe in a place that speaks the same language as them, that shares the same culture, stays within their time frame, or also just fit their configuration better. They want the same TPS or OIS as what they're going to be using for their training. And so they want different options for training. And this is why we chose to partner with different institutions to offer different choices to people going through training. Finally, we talked about it, innovation. IBA is working hard on dynamic arc, conformal flash, eye on the gantry, or adaptive proton therapy. And this, of course, requires as well training on these new techniques. So what is Proton Therapy Academy? It's a global hub for protocol therapy training and education. It's an easily accessible platform on protontherapy-academy.com. It's an experienced network of proton therapy centers. And finally, it's scalable. Trainings will scale together with proton therapy. As we talked about it with innovation, as it goes on, we will also adapt the educational offering that we have. So you can scan the QR code here to explore Proton Therapy Academy, or you can go to your URL that I just gave you, but we'll give you other opportunities to explore the website by scanning the code in a few minutes. So just a brief overview of our Proton Therapy Academy network members. Those are the members that contribute to the content on Proton Therapy Academy. It is peer-reviewed content with customized learning paths by role, online modules with video and quizzes, and all of them also offer on-site training. So today we have the European Institute of Oncology in Milan, but we also work with UMCG in the Netherlands, Apollo in India, Corewell in the US, PSI in Switzerland, Kansas in Missouri, Quiron Salud in Spain, New York Proton Center, Baptist Health in Miami, Mass General Brigham in Boston, and Heidelberg in Germany. And it's very important, and we're very proud to say that we've been endorsed as well by PTCOG, the professional organization from particle therapy who supports Proton Therapy Academy and its projects. We organized the first webinar together with our first two centers a couple months ago. That was with New York and with Miami. And now today we bring you this one with IEO. So this is part of a global webinar series on optimizing proton therapy because many centers face pressure to do more with less. And so we want to bring you these quarterly webinars on proton therapy with some of our expert network members that bring you real world strategies on how to optimize your patient throughput. And so you can follow us on LinkedIn by scanning the QR code below to really stay up to date with our future webinars. So as I mentioned, we had our first webinar with Andrew Rowe and Chuck Simone from Miami and New York, respectively. The second webinar is on optimizing proton therapy through hypofractionation with Barbara Jacek, Daniela Alterio, and Luca Bergamaschi. And then we will have a third webinar coming soon, so don't forget to follow us on LinkedIn to have all the information that you need. Some practical details, please type your questions in the Q&A box. You can find it here at the probably top left of your screen. And there will be a recording of this webinar, which will be shared afterwards. So now I would like to hand it over to Barbara Jacek, who will be moderating this webinar and introducing today's speakers. So Professor Jacek, the mic is yours.
Thank you, Aurelian. Thank you for the introduction. I'm Barbara Jacek, radiation oncologist from Milano, Italy. I'm delighted to welcome you on this webinar on optimizing proton therapy through hypofractionation, evidence and early experience. As radiation oncology community, we know that we have now level 1 evidence for hypofractionation in photon radiotherapy. And this is the case for the majority of solid tumors, big killers like breast cancer, prostate cancer, early non-small cell lung cancer, rectal cancer, or even glioblastoma. We use a lot of hypofractionation and it's evidence-based. This is not the case for proton therapy. We are still lacking some evidence, but fortunately new evidence is coming, and I'm sure that in this hour, you will see the evidence that we have already, the rationale, and also the preliminary experience from our center. Hypofractionation is obviously beneficial for, I would say, all stakeholders here, because first of all, patients, from their point of view, it's a convenient treatment. They don't need to travel as much to the hospital, so it is usually short treatment and well received by patients. It's definitely hospital or health care system friendly because there you can reduce waiting list, but it's also climate friendly. So because you reduce the impact on the climate, reducing the travels from and to the hospital. So I think that having biological rationale and having more and more evidence, we should think how to move to hypofractionation. And I'm sure that the evidence of we will see today will give us more confidence in this field. And I'm delighted to have here with me Dr. Luca Bergamaschi and Dr. Daniela Alterio. Luca Bergamaschi will speak first. So Luca Bergamaschi graduated in medicine at the University of Milan in 2017 and completed his specialization in radiation oncology in 2022. at the University of Milan after 3 months observership at Quirónsalud Proton Therapy Center in Madrid, Spain. He has been working as radiation oncologist at the Division of Radiation Oncology here in Yeo, Milano, since 2022. His main clinical research activities are focused on head and neck cancers, gastrointestinal tumors, and proton therapy. Today, Luca will show us the evidence in the field of hypofractionation, time for change. So, Luca, the floor is yours.
Thank you very much, Prof. Jureczek, for your generous introduction. I will try to share my screen. Okay, I think it's correct now. So this is my today's agenda. I will talk about, first of all, the rationale for hypofractionation in proton therapy, while the second part of this presentation is about the tumor sites with the strongest evidence in this setting, and the last part with some take-home messages. So let me start with the first part, so about the rationale of hypofractionation. We know that there are lots of advantages. For example, the first of the advantage is the comparable or even superior in some clinical cases oncological efficacy because of the increased therapeutic ratio that we have in some kind of tumors, especially with low alpha beta ratio, and also the possibility to reduce the lymphopenia that may eventually enhance the immune response against the tumor. We know also that hypofractionation is better for the patient because the treatment is faster, it requires fewer days at the RT department, and so fewer work days lost. And also we know that it could be better for the healthcare system in general and the RT department itself, because it requires a shorter waiting list, and so more patients could be treated. And the last thing, it's the lower environmental impact. So indeed, we can say that hypofractionation is a way to optimize the RT treatments and also proton therapy. So what we know yet from the photons, we know that there are, in the last year, lots of clinical trials, very important, so practice-changing clinical studies in different settings, such as breast cancer, prostate, lung, rectum, and oligometastatic disease. And thanks to the result of these randomized control studies with strong evidence, nowadays we can say that this treatment is the gold standard for photon therapy. So the question is, can we also consider this strategy, so hypofractionation, even with protons? We know that there are some main concerns regarding this topic. We saw that also in the survey that we recently conducted across the proton therapy centers in Europe. Some of the concerns are similar to the photon group. For example, the increased risk of acute and late adverse events because of the risk of late normal tissue damage. But some concerns are specific for the proton therapy. For example, the greater impact of radiobiological uncertainties. So, for example, how RBE varies depending on the fractionation, but also how to deal the motion management of the lesion during the treatment delivery, and especially the lack of robust scientific evidence that we don't have yet in proton therapy. So about the RBE dependence in hypofractionation, I would like to mention this important publication from Frederick. So the proton RBE dependence on dose in the setting on hypofractionation. The first question of the author in this paper is, does the RBE for protons vary with the dose? And the second one is, if so, does it matter from a clinical point of view? The conclusion of the authors in this paper is that in hypofractionated proton therapy, the RBE effects are expected to be rather suppressed than amplified, and so even less clinical manifestation is expected. So this is a positive thing. The negative thing when we have an hypofractionation treatment is that we have to consider a greater impact of uncertainties that may not be compensated because of the absence of the averaging effect that we have in conventional treatment. But it's very useful in clinical practice nowadays is that we have different RBE models that are used for the ALITI evaluation in proton therapy. So some of the models, for example, the McNamara one, is suitable for conventional fractionation, so true gray for fraction. But when we perform hyperfractionation, other models are better, for example, this one for carabine. So instead, to answer to the lack of robust scientific evidence, probably we have to say that we need more evidence on hyperfractionation even with protons. So we need more results from randomized control trials, systematic reviews, before we can say that the time for change has come. And this is the research on PubMed, considering the combined two words, hyperfractionation and proton therapy. And as you can see, in the very last recent years, there was a growing interest in this setting. So probably the future is very close. And also, I would like to mention this very recent publication from the team of experts in the field of proton therapy. In this paper, a key challenge remains in how to expand the access to proton therapy in order to maximize the clinical benefit. And one of the potential strategy that was proposed is to explore hyperfractionation. So you can see how this is really a hot topic nowadays. And to start to mention the review of the literature about this setting, I would like to start with this important review from 2022. First name was Santos, about the role of hyperfractionation in proton therapy. This review included 57 manuscripts reporting clinical outcomes involving this strategy. And as you can see, the most common treatment regions were prostate, lung, and liver. The conclusion of this review was that this strategy can be well tolerated because the similar incidence of adverse events was reported between the standard and the hyperfractionated patients. And also that future clinical trials are still needed to determine the optimal fractionation regime. And also, I would like to mention this very recent another review. This time is both for particle therapy, so both for proton therapy and carbon ions. And also in this review, the more evidences were found in prostate, lung, and gastrointestinal tumor. And the results was that hyperfractionated particle therapy could improve patient convenience and enhance therapeutic ratio. So moving on now to the second part of my presentation. Now I would like to show you the tumor sites with the strongest evidence. And I would like to start with the prostate cancer. In this setting, there are lot of evidences already published. The first trials were about the low risk, the intermediate risk in 5 fraction with proton therapy, with good results both in terms of adverse events and oncological outcomes. Then other evidences from, in this case, moderately hyperfractionated treatment, considering also high-risk prostate cancer, incorporating the pelvis into the radiation field with good results. And also I would like to mention our experience from Yale. This is a systematic review and meta-analysis, first name Corrao, comparing photon versus proton hyperfractionation in this setting, with better results in the proton therapy arm for grade more than 2 side effects, and also improved 5-year biochemical relapse-free survival. And as the last paper I would like to mention is this very recent publication about 10 years outcomes, so quite a long follow-up with moderately hyperfractionated proton therapy for prostate cancer with good results. Some practical consideration when we talk about the prostate, we have to consider that proton therapy is more sensitive than photon therapy to anatomical variation. So eventual changes in rectal or bladder filling can cause some range shifts, potentially resulting in over or under dosage both to the target and the organ at risk. So there are some mitigation that we have to take into account. For example, the robust planning and optimization, the use of IGRT, so daily image guidance, better with combined CT, or in alternative, the use of prostate fiducial markers. And also a rectal management, so from the diet to the insertion of rectal spacers and the bladder volume control. Also, we have to take into account the prostate motion, especially in ultra hyperfractionating schedule. The intrafraction motion of the prostate could be critical, leading to potential hot or cold spots into the target. Now moving on with the lung cancer. Also in this case, there are lots of already published studies. For example, someone from the early stage non-small cell lung cancer with good results in 10 or in 8 fractions. Moving on to more locally advanced stage of disease, also in combination with chemoradiation. With chemotherapy, sorry. Also in this case, I would like to mention the systematic review and meta-analysis from our institute, from our team, first name Stefania Volpe. In this case, the conclusion was that this strategy was a safe and effective treatment option, especially when we can reach a higher bed, a higher biological equivalent dose, in order to obtain a better local control. And also, I would like to mention this recent publication about a very peculiar setting of radiation for recurrent lung cancer with promising result with hypofractionated proton therapy. Talking about lung, also in this case, we have to consider specific practical consideration, especially because of the respiratory motion management, because the tumor motion and the organ at risk motion may affect our accuracy, the accuracy of our treatment plan. So there are lots of strategies that are proposed also in clinical guidelines and guidelines from experts. For example, the implementation of deep inspiration breath hold technique, or the use of abdominal compression, or the implementation of DCT scan or surface-guided radiation therapy, the respiratory gating when it's possible, and the PenSMB scanning. Obviously, in this case, the patient setup is crucial, so we have to be very careful to guarantee an accurate immobilization of the patient, and the daily verification is essential with ConvinCT if it's possible. And also, the patient selection is very crucial to perform the better treatment in this case. Moving on to the liver, also in this case, there are already published lots of different trials. Now, I have chosen for you these two. The first one is for Parzen, about the unresectable liver tumors with few adverse events reported and excellent local control, especially with higher dose. And also these randomized studies, first name Bush, comparing this strategy versus transarterial chemoembolization, with advantages in the proton therapy arm, both considering progression-free survival and local control, but also fewer courses of treatment, fewer post-treatment hospitalization days, and reduced cost compared to the transarterial chemoembolization. Also in this setting, we have performed a systematic review and meta-analysis for intrahepatic cancer in Yale, and the results will be published very soon. But we have obtained an excellent result in terms of local control, especially when we can reach a higher dose. Also, in this case, the practical consideration is quite similar to the lung cancer because we have to take into account the respiratory motion of the tumor and the organ at risk. But moving on with the breast cancer, I would like to start with our critical review from our team that included in 2022 12 papers on partial breast irradiation with clear dosimetric advantage, but not so clear clinical improvement. But after this review, there were other studies that have been published. For example, this one, first name Vargas, about also ultra hypofractionation treatment with good results in the proton arm. And also this randomized study, first name Matter, conventional versus hypofractionated post-mastectomy proton radiotherapy, with promising results also for the hypofractionated arm. Also for practical consideration, we have to take into account the tumor motion, the breast motion, that may affect our accuracy, so our mitigation are very similar to the lung and the liver one. So I will want to end my presentation talking about the brain, because also in this setting we have some evidences. First of all, our systematic review considering 12 papers of benign tumors with good results. But also there are other clinical trials that have been published in both in the benign tumors such as meningiomas, but also in malignant disease, for example, glioblastoma. In this case, the treatment obviously requires advanced immobilization, so the thermoplastic mask is mandatory, and also a careful image guidance, better with the ConvinCT. In general, we have to pay attention to eventual anatomical changes between the fractions, for example, because of the tumor shrinkage, that may alter the dose distribution. But also in the setting of hypofractionation in proton therapy, we can say indeed that the sky is the limit because there are lots of ongoing clinical trials and some of them are already published, for example, in sarcoma, in chordoma, in other gastrointestinal setting, even in head and neck setting, and also have to mention the peculiar setting of the uveal melanoma where this strategy is nowadays the gold standard of treatment. So moving on with my take-home messages, I can say that hypofractionated proton therapy is emerging in different clinical scenarios. In some of them, we have already most major areas of clinical evidences, for example, prostate, lung, liver, but also breast and brain. But we can say that the list keeps expanding. So what's next? Probably we need to overcome the current barriers limiting the implementation of this strategy. We will try also to harmonize the major indication and the schemes of fractionation across our proton therapy centers. And probably we need to improve the scientific evidence supporting this treatment approach before we can say for sure that the time for a change has come. And with this final slide, I would like to thank you all for being here. Thank you for your attention. And I will hand over to Prof. Rezek for the second part of the webinar. Thank you very much.
Thank you, Dr. Bergamaschi, for this wonderful review. You see how many exciting studies and data are coming. So I think that now it's we are moving from can we do it to which patients benefit most and how we can personalize it. So with this, I would like to call Dr. Daniela Alterio to share the experience from Yale. Daniela Alterio graduated in medicine at the University of Naples in 1996 and completed her specialization in radiation oncology in 2000 at the University of Naples, Italy. Dr. Alterio has been working in the Division of Radiation Oncology here in Yale, Milan, Italy since 2001. From 2022, she is a deputy director of the division. Her main clinical and research activities are focused on head and neck cancers, image-guided radiotherapy, and particle therapy. Daniela got a lot of experience in many centers worldwide, and she is currently a chair of the EPTN ESTRO working group focused on hypofractionation on proton therapy. So, Dr. Alterio, who better than you could describe how to implement hypofractionation in the daily practice? We are eager to hear you.
Thank you, Professor Sayereczek, for the introduction. I will share my screen. Please let me know if you can see my slides.
Yes, we can see it now.
Yeah, we see it.
Okay, so good afternoon, everyone. My topic will be focused on a preliminary experience that we have in our institute.
Sorry, maybe you put presentation mode, yes, because we see the older screen. If you can
you see now?
Yeah,
perfect,
now
like
it's
this.
perfect.
Yes.
Okay. Thank you for the feedback. Okay, so this will be my agenda. I will start with the context of our institute. We are a comprehensive cancer center and we are located in the northern part of Italy, in Milan. We started as a photon-based department, and currently we have 5 linear accelerator, a brachytherapy unit, and in 2023 we started with our activity in proton therapy. Proton therapy is located in a separate building, but this building is directly connected with the Department of Radiotherapy. So it is a unique division with photons and protons. We are equipped with a Protos One IBA machine with 1 gantry and 1 room. And we started our clinical activity in November 2023, and now we have reached the number of more than 500 patients. What about the numbers? So how many patients do we treat with a hypofractionated schedule? This is the ramp-up of our institute, and starting from the beginning, as we have a great experience on the use of hypofractionation in photon-based treatments, we thought when and how we could translate this experience from photons to proton therapy. And as Luca Bergamaschi showed you before, we started with the literature review in order to understand which data have been already published. And this constitutes the start point of our clinical activity. And here you can see summarize the paper that we published, and also we organized a webinar on hypofractionation in order to collect all available data for our clinical activity. This is our case mix. So the majority of patients have urological cancer, followed by head and neck, breast, central nervous system, and so on. We treat only adult patients. And as you can see in these slides, we use conventional fractionation, but started from the beginning of our activity. We also used either moderate hypofractionation and also extreme hypofractionation. And I have divided these two categories considering more than 2.12 to 5 gray for moderate hypofractionation and more than 5 gray for extreme hypofractionation. And when we look at the fractionation schedules, as you can see, in the standard group, the majority of patients have been treated with 2 gray fractions, while for moderate hypofractionation, we generally use from 2.67 to 3 gray, while in extreme hypofractionation, we use schedules from 5 to 7 fractions, gray fractions. And if you look at the diseases that we treat with the hypofractionated schedule, we generally use an extreme hypofractionation for patients with urological cancer. In case of head and neck cancer, we generally use standard fractionation schedule, while in breast cancer, moderate fractionation. And in our case mix, about half of our patients are irradiation. And as you can see, we use hypofractionation also in patients treated with a second or in few cases also a third course of radiotherapy. But to go more in deep in the clinical aspect, here there are two cases of our patient. The first is the prostate cancer. This is a typical prostate cancer, adenocarcinoma. The histology and the multiparametric magnetic resonance showed 2 dominant lesions. So our typical dose prescription is a simultaneous integrated boost in which we prescribed for the dominant lesion 8 gray per fraction for 5 fractions, while for prostate and the third lower part of the seminar vesicles, 7.25 gray per fraction for 5 fractions. As Luca Bergamaschi told before, is very important an accurate patient preparation and positioning, because these parameters are very important in the robustness of the treatment delivery. And indeed, we put a high attention in this preparation with the patient. We ask the patient to have a filled bladder, an empty rectum, and in our daily clinical practice, we do not use spacer devices or catheter. We also give to the patient a diet, and we support him with a medical preparation. At the beginning of our activity, we started with the thermoplastic mask, but we noticed that without mask, the patient positioning was more reproducible. So currently, we are using a simple CombiFix immobilization device. Another important thing is an accurate contouring, and indeed we use the fusion with the multiparametric magnetic resonance. And here you can see different images that we use to contour not only the prostate but also the dominant lesions. And a robust treatment plan optimization. Indeed, for these cases, we always use 4 fields, 4 field entrances with the single field optimization technique. robust optimization at 5 millimeters, and robust evaluation at 3 to 5 millimeters. We need also to move our couch, and in this case, we use independent ISO centers. About the constraints that we use for protons are the same that we are using for photon-based technique. Another important thing is the accurate patient setup verification. And for this, we use a visionary RT system for patient positioning. And after this, we acquire a daily ConBeam CT. And these are only preliminary results of 49 patients treated for radiation, because as I showed you before, about half of our patients are patients treated with more courses of radiotherapy. And also in this setting, we use a hypofractionated schedule, and these preliminary results show a very good toxicity profile, either as acute and long-term side effects. Moving to prostate cancer, this is a typical case of breast cancer, in which we have treated the patient with proton therapy because of the presence of sclerodermia. And also in this case, we use a simultaneous integrated boost using 2.67 gray per fraction for the whole breast and 3.2 gray per fraction for the boost. This is the immobilization system that we use in our clinical practice. And as we don't have a breath hold system, currently we are treating this patient with a free breathing technique. So we acquire a 4D computed tomography CT, and then we have a dedicated script on restation that allows us to quantify the patient movement. And if the movement is lower than 2 millimeters, we candidate the patient to proton therapy. Otherwise, for us, it's not possible to treat a patient with proton, and we propose a photon-based technique. Again, we use a multiple field entrances with the 3 fields, and again, a single field optimization system with the robust optimization at 5 millimeters and robust evaluation at 5 millimeters. As we know that the LIT is accumulated with this technique, the LIT is mainly present on the ribs. We are thinking to move from a breathing technique to a breath hold technique, because now we are equipped with a vision RT also in the simulation CT. So we would like to optimize this technique by use tangential fields. Also, in this case, we put great attention in the patient setup verification. Indeed, we use Vision RT not only for patient positioning, but in this case also for patient monitoring. And we set the threshold at 3 millimeters. So if the patient have a breath larger than 3 millimeters, the beam stops automatically. And again, we use a daily ConBeam CT for the patient positioning. These are other preliminary data on 20 patients treated for radiation. And as you can see, again, the acute and late tolerance is very, very low. Very, very high, because the toxicity is very low. Also, in the setting of irradiation, we presented our results on the preliminary 60 patients, and the clinical outcome and toxicity were quite favorable. So these are patients treated in our clinical daily activity, but all these data are collected in our registry. Our registry is a real-world data collection of daily clinical practice, and so all these data are prospectively and robustly collected in the registry. What about the European scenario? As Professoressa Jerecek told before, we are currently coordinating an European group focused on hypofractionation, and we did a survey that showed that now currently the majority of the patients are treating patients with hypofractionated schedules in daily clinical practice. Indeed, as you can see here, only about 10% of the centers do not use hypofractionation in daily clinical practice, and the diseases in which hypofractionation is mainly used are central nervous system, breast, head and neck, and prostate cancer, and these diseases are in line with our case mix. So the take-home messages are that hypofractionated schedules are feasible also in the setting of proton therapy, that this approach is currently used in the daily clinical practice in the great majority of European centers, that for sure is mandatory and accurate workflow from the simulation CT to the patient setup verification. Also, a robust treatment plan optimization is mandatory, and the key point remain the clinical indication and patient selection. And with this slide, I thank you for your attention.
Thank you, Dr. Alterio. Wonderful overview of the experience and how we implemented it. So I think it is useful for our participants. Let's start with some comments and questions. Obviously, there are many. I invite all the participants to write comments or questions in the Q&A box. In the meantime, while waiting for
I see your first one, Professor Jerecek.
That's
Tony
great.
Wong is asking, how do you count and correct for intrafraction error for your 4-field SBRT prostate? Maybe Dr. Altero, you want to take this one?
Yes, so the beam delivery is quite short. If we have some problem of patient positioning and the general length of the session is over the normal length of the session, we acquired a new COM-beam CT. So generally, this doesn't occur because after the patient is positioned properly and after the COM-beam CT is acquired, 4 fields are not so long, so it's not necessary. But in case of some problem, we acquire a second COM-beam CT during the treatment.
So may I add only that obviously we work on the patient preparation, and then we try to keep the treatment as short as possible to reduce the organ motion during the session. And as Dr. Alterio said, whenever indicated, if for any reason the treatment is long or there is any issue about the organ motion, we can re-image patient during the treatment. Okay, I have also some questions. So, and then Dr. Jongen, if you see any comments, because I don't see easily on the screen, so you can obviously interrupt me if there are new questions.
I don't see for now, but please feel free to ask your questions in the Q&A, and then we can address them. But Professor Jerecek, I'll give you the next question in the meantime.
So I have the question for our two speakers. So if you want to start, and let's say you are the colleagues with no experience in hypofractionation in proton therapy, who would be the first patient or the first tumor site, Daniela Alterio, Dr. Luca Bergamaschi, that you would start as a first experience? When would you be more confident with which kind of patient or tumor site?
I can start, Daniela, if you agree. Probably I will choose to treat a meningioma for the first patient for several reasons. First of all, we have strong evidences from the photon treatments, for example, the stereotactic treatment in 5 fractions with excellent results. And we also have, as you have seen before, some evidences already published also for proton therapy with hypofractionation scheme. So, for example, when the dimension of the meningioma is more than 3 centimeters, we can prefer even here in Yale, which is a comprehensive cancer center. So we have different treatment options to choose proton therapy because of these reasons. And also, I think it's better to start with some CNS lesions, for example, the meningioma, because we don't have problems, issues regarding the motion of the treatment. The thermoplastic mask is perfect to guarantee the accuracy of the delivery. And also, we don't expect so many changes of the lesions between the fractions because it's a meningioma, it's a benign tumor. So probably it's I choose the meningioma, yes. It's my choice.
Yeah, and
Yes,
Dr. Alterio?
Yes, I completely agree with Luca because the central nervous system has no problem of organ motion, of internal movement, and it is true. But we also know that with proton therapy, we could have a higher rate of radionecrosis. So we should put a higher attention of the beam entrance. And in this case, we also look at the LIT, not for not for a robust optimization, but only to see where the LIT is, and we avoid a high LIT on the organs at risk, for example, on the brain stem. So this is the only criticism that I can see in this kind of patient. So we use often 3 or 4 fields in order to have a very robust plan.
So what would be your second patient, Dr. Alterio? And then we move because I see questions coming also from our participants, but just to complete this introduction. So meningioma, and from your side, what would be the second
Breast
or your
cancer.
first?
Yes, the breast cancer, for example, is a very simple technique, also with a free breathing technique, because as I told you before, we have not yet a breath hold technique, but with some specific script in restation that can be customized, we could analyze the patient movement and using again at least three fields in the direction of the patient breathing, the plan is very robust. If you have a breath hold technique, is even better because you can use tangential fields, so avoiding or reducing the LIT on the ribs, because you know that with proton therapy there are some data that show that the risk of rib fracture could be a little bit higher in protons compared to photons. So this is another criticism that you have to take into account for breast cancer. But among all the moving lesion, let me say, in the lung or in the mediastinum or abdomen and pelvis, another, for example, very let me say simple region is the lateral region of the pelvis. If you have lesions in the lateral pelvic wall, so with the internal organs only on the exit of the beam, it is quite simple to have a robust plan, also with an hypofractionated schedule, not for central lesion, but only for lateral lesion of the pelvis. This is another, so let me say, good patient to start with hypofractionation.
Thank you, Dr. Alterio, for these advices, and I think very practical ones. So now I see a couple of questions, so let's move to the questions from our participants. The first one, how do clinical indications change when moving from traditional fractionation to hypofractionation, such as prescription? Do you want to match biological effects? So how do you change the prescription mode?
No, we have not changed our prescription. So from the beginning, we started with the moderate hypofractionation, but we had a great experience in photon-based technique, also for the patient positioning, for the setup. So we currently are using the same fractionation in photons and in proton therapy.
Also, I would like to add that doing our literature review before starting the clinical practice was very useful because we have checked if there were any prescriptions difference from the photon side, and so to be sure that we can prescribe with strong, robust evidence in every setting. So I think this is the best option.
Okay, and now the second one is about prostate cancer. So again, for a prostate cancer with seminal vesicles and lymph nodes, how do you handle the hypofractionated treatment? I would add only that we rarely treat lymph nodes. As you know, there are 5 randomized trials in photon radiotherapy, and only one showed a benefit. So we really rarely do pelvic treatment as well. And every time you do it, obviously, it's the same issue. Also for photon therapy, here in proton therapy, it will be more pronounced, the match between prostate and the lymph nodes. But again, if we do lymph nodes, we usually don't do extreme hypofractionation on pelvic lymph nodes. So these are rare situations, and they must be managed, obviously, on the personal basis, single patients. Maybe Luca and Daniela, I want to add something. With big fields, how you manage, but you know that the issue is that if you do hypofractionation, you usually try to use as small volumes as possible. So that's why this issue is not common, that you have to treat large volume with high dose per fraction.
Yes, it's not common. In the paper that I've shown in my presentation, that considering also the incorporation of the pelvis, the lective pelvis in this case, was with 25 fractions. So indeed not ultra hypofractionation, but moderately hypofractionation with good results. But yes, we prefer to treat, as you have said, a small lesion in this setting when it's possible.
Yes, we move from, yes, no, only to say that we move to extremely hypofractionation to moderate hypofractionation in case of large lesion. Always we prefer to avoid extreme hypofractionation in every body site.
Yes, always the issue of volume and dose. So the rule is coming also from photon therapy, and we follow it here. So if you increase the dose, you try to keep the volume as small as possible. So now, have you treated primary liver cancer with 5 fractions? Any specific situations? Are there any specific situations?
No, at the moment, not yet. We treat only a very a patient with a large lesion. But as we don't have a breath hold and other so technique to minimize the movement, we are not so confident to treat this kind of lesion. We started just a few weeks ago with a breath hold technique using vision RT. For a mediastinal lesion, but we are starting just in this week with this technique. So we currently, also because in Italy, liver cancer is not, the cost of the treatment is not covered by the health national system. So we are not allowed to treat this patient. In any case, we have to study how to do in order to reduce the movement, to minimize the liver movement and breathing movement.
Yeah, so sometimes, the cases you treat will depend also on your national situation, local situation. In Italy, we have the list of indications, and unfortunately, liver cancer is not yet on the list. We have the data, but it is not yet on the list. We are working on this definitely. So that's why our experience is limited, but we have some single cases already treated, not many. The next question, why use for DCT to select breast patients? Normally, the dosimetry will not be affected too much due to the enfance entry angles. So, Daniela, should we use
can you repeat the beginning of the sentence?
Why use for DCT? Okay.
Okay. Yes, okay, because we have to be sure that the breathing movement is not so high, because some patients have a so high breathing movement, and we know that if you use orthogonal fields, these have not a so much impact. But as we want to start cautiously also with this kind of treatment, we prefer to treat patients with a higher compliance, so a patient that can breathe regularly and with a minimum of the movement. This is a cautious approach that we had, but I agree that we could also enlarge the cutoff that we have, because if you use orthogonal fields, probably this have not a so high impact on the treatment robustness.
Thank you.
I think we had some very good questions, and we can start wrapping up if that's okay with everyone. So I want to thank all the speakers. Thank you, Professor Jacek, for the great moderating and the engaging introduction that you did for us. Thank you, Dr. Begamaski. I'm sorry if I'm butchering your name. It's not easy. Thank you for your interesting talk, and same to you, Dr. Alterio. Thank you very much, and also for addressing the different questions that the audience had. So we want to thank you, everyone, for attending. Please follow us on our LinkedIn page to stay up to date with the next webinar that will take place after the summer. And we look forward to seeing some of you at PTCOG in Deauville in France. So thank you very much to everyone.
Thank
Thank
you
you very
all
much.
for joining us. Thank you. And see you soon, hopefully at PTCOG.
Thank you.
Thank you.